am going
to Erica Blanton with Palisades Village, and I just want to welcome everyone to this presentation, very timely, on home care, home health, and hospice. I see some familiar faces out there, and I know who appreciate MaryAnn's expertise and ability to make the complexities of our healthcare system just a little bit more understandable, because in their current state, it's pretty darn difficult. She has a long career in senior level positions in a variety of healthcare settings, including hospice and home care and healthcare. 5 years ago, she retired as the division director of aging and adult services for City of Alexandria. And we were lucky enough to get her as a volunteer, as well. She's also running her own consulting business of Griffin Healthcare Solutions. I encourage you to join us for future episodes of this series of protecting your most valuable asset, your health, which we've been running. We'll be running for another couple months. And if you've missed any of the episodes in the past, we have a YouTube channel and you can view them there. So without further ado, I turn it over to MaryAnn and tell us about home care, health care, and hospice.
Good morning, everyone. It is very nice to be here. I have a froggy voice this morning, so I was drinking tea with honey and someone said apple cider vinegar, so I'm going to do the very best that I can. As Erica mentioned, I actually have had many, many years of experience in both hospice, home care, and home health. And I think bottom line that I have found over the years is that there's a big difference and people really don't actually understand for the most part. So I'm going to go ahead and get started here. Erica, could I just take a second? On my screen, I'm seeing live transcription and who's coming in. Can I just close both of those?
Close the who's coming in part.
Okay.
Yes, you can close it at the top as well. Yes.
Close. Okay. All right. Okay. Let's begin by talking about home health care. So what home health, and I keep emphasizing the word health because that's going to be really important in understanding the difference between these. Home health is a whole range of skilled services that are covered in your home, and they're covered by Medicare Part A. And the goal is really, in the most broad sense, is a rehabilitation emphasis. So you treat an illness or an injury, and it's specifically focused on treatment and rehab. Now, it is thought to be less expensive, more convenient, and equally effective to care in a nursing home. And I would be willing to say, given the staffing issues that nursing homes have, it's probably more effective because it does occur in your home. So the goal is to treat the illness or injury, and the emphasis again is on regaining your independence, maintaining your current condition, or getting you back to where you were before, or at least slowing the decline that you might be experiencing. Big question that comes up all the time is, how does this get paid for? Well, a person must have A and B, and you have to meet a couple of criteria. First is the doctor has to actually write a plan of care to certify you either need intermittent skilled care, physical or occupational therapy, and speech and language and/or speech and language pathology. One of the things, let me just sidebar for a moment. We're going to convert the slides into handouts, and Erica can send these out to you. So that's why I put the links on here, so that if you wanted to go explore a little more for yourself, you'd be able to do that. So who's eligible? Now, this is an interesting condition that Medicare has, and I'm not sure how reasonable it is anymore, but the doctor has to actually write that you're homebound. So the three criteria to define homebound is that you're not recommended to leave your home, that your condition keeps you from leaving home without some sort of assistance, and or leaving home takes considerable or taxing effort. I would say that having a doctor write that is really important to be eligible, but many people do leave for things other than medical treatment or to go to church. You know, you can't actually go get your hair done or go to play bingo, but there's probably other things for which you can leave your house without having the Medicare police come and arrest you on the street. Well, some of the things that you're seeing getting treated are wound care. Um, some of the things that can be included even are caregiver and patient education. So, for example, if somebody's a newly diagnosed diabetic, there are lots of things to learn, and that can happen in the home. There are people who go home from the hospital with IVs or feeding tubes, all of which are pretty scary if they're happening in your home. But the common thread here is that all of these have to be skilled services. And what that means is they're provided by a licensed professional. So the conditions for a PT, occupational therapy, or speech, they're pretty specific, and they have to continue to document these after every visit. It's conditions expected to improve in a reasonable period of time. And reasonable, in large part, I think, depends upon how old you are, how impaired you were before all of this happened, that you require a skilled therapist. This just can't be having your spouse help you walk from point A to point B. And that therapists have to document, is the frequency and duration reasonable? And again, reasonable in quotation marks, because it depends on the individual person's needs. Good news about this too is that Medicare has recently expanded home health, and that they now pay for medical social services as long as it's provided by an MSW social worker and it's ordered by the doctor. Supplies like wound dressing, they're very, very expensive, and so those can be provided. And all of this, again, is paid for under Medicare Part A. Now, if you need a walker or a wheelchair or a hospital bed or some sort of equipment, that gets paid under Part B. And what will happen is that your Medigap supplemental policy will pay the remaining 20%. But all of the other services under home health are paid for under Medicare. Here's some real-time examples. Let's say you fell and you fractured your hip and you had a hip replacement. You don't want to go to a nursing home. You say, I really want to go home. So you could have physical therapy in your home. Speech therapy following a major stroke is a really common service. An industrial accident, you lose the use of your hand, your arm, whatever. You can have occupational therapy in your home to restore the function. And one of the things that's very common for people who have strokes is they have huge psycho-emotional issues, and Medicare will pay for an MSW social worker to really intervene to help resolve some of those issues. And again, as I mentioned, the patient and caregiver education is really important, and that's actually relatively newly added. A newly diagnosed diabetic. Once upon a time, there was a hospital over in Arlington called Pentagon City Hospital. And I actually was hired, and this has been several decades ago, it feels like, but I was actually hired for the purposes of setting up wound management, diabetes education, and osteoporosis. And the impact that newly diagnosed diabetes has, you just can't even underestimate what that involves. And so relatively newly, again, added was the fact that Medicare Part A will allow you to get those skills, administer the injections, and teach you everything you need to know in your home. Hard to imagine that people come home with NG tubes, but they do. And that's really pretty scary for most spouses or caregivers, because you come home with a feeding tube and it's scary. Again, coming home with a colostomy or any sort of ostomy care is, again, very, very scary if you're the spouse or live-in caregiver. So that also is covered under Part A. How this gets paid for is that Medicare A, again, keep stressing A because there are no co-payments or deductibles in this, which is the good news. What happens is the Medicare will pay an agency what they call an episode of care. So it's a 60-day period of time and it's all inclusive. It includes the social work, the physical therapist, occupational therapist, the nursing visits, etc. And so you pay nothing for home health services, but you would pay 20% of anything that's the durable medical equipment like beds and walkers and wheelchairs. So how do you select an agency? Well, one thing I can tell you for sure is that not all agencies are created equal. And there are some that are really good and some that are not so good. And Medicare actually has a place on the Medicare.gov website where you can actually compare the agencies. So I put that link in there too. So when you get copies of these, you'll be able to go there. But here's what it looks like. This is the Medicare.gov website. And if you wanted to compare agencies, you would go to the tab on the left-hand side. You can't really see it because this is a screenshot, but it does allow you to compare nursing homes and hospitals. So you put your location in with your zip code, and then you put in your provider type. And you don't, at this point, pretend you don't know the name of an agency because you're just looking for the first time. You click on the search bar. So here is sort of an example, which again is really hard to see, but it was the best I can do for a screenshot. But it lists alphabetically, if you look on the left-hand side, it lists alphabetically the home health agencies according to your zip code. And it gives you quality ratings and it gives you patient survey ratings. Now, I am not entirely clear because I didn't spend additional time doing this, but I'm not sure in this case why this agency got a 4.5 for quality, but the patient survey ratings were 3. Okay. So that's a little concerning in terms of the validity of the scores, but it's certainly worth looking if you're considering the home health agency. The other person that can actually give you a hand in this is, especially if you're being discharged from the hospital, the discharge planner or social worker as you're leaving the hospital can tell you a lot about the agencies that they work with, and that's a really good place to start. And then you can add on to that if you want to come and look at the Medicare website. So let's talk about home care, because home care is entirely different than home health care. And I'm going to stress again and again and again, health versus care. Let's look right at the very beginning here at the difference. A home health agency must be skilled care. That means it has to be provided by a licensed professional who's going to perform the services. So I ask you to think health. And remember, when we looked at the definition, we were talking about rehabilitation, healing, treatment, etc. That's in the purview of health. So home care, that means things like homemaker, personal care, bathing, dressing, grooming, that sort of thing. Generally, agencies will provide that through a certified nursing assistant or a home care aide. So in that case, what you do is think care versus health. So home care agencies, they cover the waterfront. There's hundreds of home care. I think in the DC metro area, and I haven't looked for a little while, but I think there's something like 1,800 home care agencies in the DC metropolitan area. And some are chains and some are locally owned and operated and some are nonprofits. But the important thing to realize here is that there is no Medicare coverage for these non-skilled home care. So people either pay privately or they use their long-term care insurance if they have it. So looking at the costs on average in the DC metro area, people who are called homemakers, those are people who don't actually touch the patient. They clean, they cook, they may drive you to the grocery store, to a medical appointment, etc. And their costs are between $25 and $27 an hour. And then there's the home care aides, which are generally they're certified as a certified nursing assistant or a home health aide, which means they have a level of education and they actually have a certification. And so those are the individuals that would help you dress and shower and go to the toilet or do any kind of grooming. So the difference is the latter can actually put their hands on you. The other ones simply cook and clean and run your errands for you. And I don't mean simply to berate them. I mean, that's the difference between the two. So the interesting thing I think is important to know, because it really helps when you think about cost for this. The average cost, as we said, is between $25 and $30 an hour. And all of the agencies require a 4-hour minimum. So the minimum that you'd be paying for a visit from a home care agency, let's say would be at the lowest rate, $25 an hour, you'd be paying for 4 hours. So the question is, why does it have to be 4 hours? Well, I have done, since I retired, I've done a fair amount of training actually with a couple of the home care agencies locally. And I would tell you that it makes it very difficult to schedule staff if you're traveling between one person's house and another. And frankly, a lot of the people who work in home care have to use public transportation. They don't have their own cars. So it makes it really difficult to try to schedule 3 people in a day. Now, someone might come to resent the fact that they have to have a 4-hour minimum. They'll say, well, I don't need 4 hours to take a shower. One of the things that you can do, for example, is to ask somebody to straighten up for you or do your dishes that are sitting in the sink. So you could expand the tasks that they're doing and maximize the 4 hours that you're required from the agency. So 90% of the home care agencies charge by the hour. The in-home care costs, interestingly enough, are based on your location. So I would say that if you're in Georgetown or the Palisades or anywhere in the city, you're going to pay a higher rate than if you were out in Gaithersburg, for example. And if you have 44 hours of care in a week, the median cost of that, and we're going to look at a chart in just a minute and in another slide to compare that cost, but about $4,400 a month is what you could expect to spend. And keep in mind, as I said before, none of this is covered by Medicare. This is out of your pocket, or if you have long-term care insurance will cover this. Now, what about people who say they need 24/7 care in the home? Oftentimes, the most dangerous part of a person's day is during the night. And so you may get family members to be able to kind of pinch hit during the day, or neighbors, or pay somebody privately. But if a person needs 24/7, when they talk about non-sleeping visits, that means you're hiring somebody to be awake for 24 hours a day. And that's covered either by 3 caregivers working 8-hour shifts or 2 caregivers working 12-hour shifts. And you could estimate, given that equates to 720 hours to have somebody in your home 24/7, it's about $17,000 a month. I know that all of you have heard people say, and maybe even yourself, that you said, gee whiz, we need somebody around the clock. I think it's important to recognize how expensive round the clock care is. Now, there's another category called sleeping visits. And what that means, it doesn't mean you're hiring somebody to sleep. But there are certain people whose condition is such that they actually need full-time care, but they generally sleep through the night, so that the aide doesn't necessarily have to be awake. But what they have to do is have some kind of a monitor or a beeper or something and be in proximity to the person. So in that case, you would have somebody on a 10 to 12-hour shift, and the median cost of doing that with a 12-hour sleeping shift is about $1,200, almost $13,000 a month. Now that sounds really expensive, but I'm going to tell you that it's not as expensive as somebody being in a nursing home. So let me just get this slide here. I think it's intuitively obvious that home care costs increase as the person's need increases. So if you wanted to ballpark how much it would cost to have somebody in your home, this is the example of that. The home care services, I think, are a really key factor, though, and I'm a big advocate because I'm a member of Palisades Village and because I just believe that most people, I think it's been proven, most people really want to age in place, and getting home care services is a key in allowing people to actually age in their homes. But as you can see, the costs go up. If you have 7 hours a week in your home, it probably should have been 8 hours. I'm sorry, that's probably a typo, or 15 hours or 30 hours. It does get up there. It gets very pricey. So here's the big question, and people stop me on the street. I have a dog, so I walk like a lot every day, and it's pretty common. I live in Foxhall Village, and it's pretty common for me to people to stop me on the street or call me up and say, wow, my mom's going to need some more care. Should we hire somebody privately or should we use an agency? Well, there's a lot of factors in making that decision, so I'm going to walk us through those. If you privately hire somebody versus using an agency, you are probably looking at lower hourly costs, particularly when it comes to hiring somebody who has had some experience. I would say, just off the cuff, I think $20 an hour is probably what you can spend on the person. Some people want $25 an hour, but even still, even if it was $25 an hour, the one thing about a private hire is you're not locked into the 4 hours a day. If what you need is 2 hours to have somebody come in and help your loved one brush their teeth, take a shower, whatever, you're not locked into that 4-hour minimum. One of the things you would absolutely want to do if you're hiring someone privately is you're going to pay for a criminal background check. And you're going to pay for a driving record check if it's somebody that you expect to be able to transport your loved one. A challenge on this one is that private caregivers are not likely to have workers' compensation. So if there's an accident or the accident could be potentially expensive for families because this person is not covered under workers' comp. You become the employer. And that is a complicated process. You have to begin to take out taxes, you withhold Medicare payments. You have to determine with them, you'd write a contract in such a way that says you would do this. You might hire them as what they call a 1099 employee, which means you have to provide a statement at the end of the year. You don't have to withhold the taxes, but you have to provide a documentation of how many hours they worked for you and how much you paid them. And then it's up to them, God, and the IRS to determine what their taxes are. So things to consider. I would absolutely try, if you can, to get references from other people if you're hiring privately, and you certainly want to interview the person. You need to determine what their skill level is and what their experience is. And it is probably two of the hardest things in the world. And I say this not firsthand, not exactly firsthand, but having spent time with folks who do work in the field. Two of the most difficult things in the whole wide world for a home care aide to get a person to do is to let them brush their teeth or take a shower. You have to have an amazing amount of skill and savvy and patience, and not everybody has that. Oftentimes, the person's dealing with someone with dementia, and I think, as most of you know, it's pretty common for people with advanced dementia that they oftentimes can become combative and they lash out. You have to have a person who's physically able to withstand that, as well as somebody whose ego is intact, and if they're called bad names, they're not going to take it personally. So it's really critical, I think, to observe when you're interviewing that person in your home. You observe how they're relating to the person for whom they'll be providing the care. I mean, what's the chemistry like? You can pretty much judge that, I think, on a couple of interactions. So other things to consider. Can they be flexible? I mean, what if you all of a sudden need more hours or you need fewer hours? And this is a really key one right here. What happens if they're sick or they need a day off? They want to be the chaperone on their grandchildren's school trip to the zoo, or they get sick. I mean, what kind of supports do you have that you could put in place if they need a day off for whatever reason, or they get sick? And again, I mentioned criminal background check and driving records. You need to get very clear up front and put it in writing what the salary expectations are. You need to spell out what the expectations are for you, for their hours and the days they'll be there. And I would seriously recommend that you draft, and you can probably do this yourself. I don't think you need to pay, a $1,500 an hour attorney. I think you draft a contract. I mean, this is what I agreed to. This is the number of hours. This is the number of days of the week. And I would seriously consider that you offer them a trial period. So again, back to the employment, you withhold taxes, potentially your Social Security. And that's a big thing. I mean, a lot of people just don't want to be bothered. They want the safety net of an agency. So you spend less, you may actually get better care, possibly, who's coming into your home. So there are multiple things to consider. Now let's talk about an agency versus the actual home care. I mean, the privately hire. Agencies, I think across the board, you're going to pay more money. But it also removes any of the scheduling or the paperwork burden from you. And it also gives you the assurance, or should give you the assurance, should being the operative word, that if the caregiver that's been coming to you is either sick or unable to come, the agency has another aide that's available to fill in the gaps. Most of the agencies all hire certified nursing assistants, and many of them will actually pay for the continuing education requirements so that the nurses' aides can keep their skills up to date. The agency has the insurance, they pay the taxes, they can do all of the paperwork that would otherwise be required if you were hiring someone privately. So the question is, how do you select an agency? Looking at, because as I said, again, there are about 1,800 home care agencies, and that's a pretty daunting task. The first thing I would ask in our era of COVID is, what about PPEs? And I would tell you an unfortunate story that actually just happened in real time. A friend of mine had a parent who was pretty ill, pretty advanced, and the home care agency, one that is certified and is generally well regarded in the DC metro area, actually sent an aide in that they were going to be paying for, and the person was coughing. And my friend's mother said, "You're coughing, are you vaccinated?" And the aide said no. So long story short, the person for whom they were supposed to be providing with the care actually was admitted to the ICU and died. So I absolutely say, whether you're private hire or whether the agencies, you need to know what the PPE is, and you need to have them show you a vaccination certificate when they set foot in your front door. I would ask doctors or family or friends if they have recommendations. You can call any of these agencies. You can ask for references from them. The agencies also have something called a patient's bill of rights, and that says kind of what their expectations are of you. Like, you have to pay on time, you can't abuse the caregiver, that you can't, make them stay longer than you agreed to, and that when you have somebody come to your home, you need to make sure, again, that they're comfortable with the person for whom they're going to be providing the care. You're going to ask if they're licensed by the state. That is so important, because even though Medicare doesn't pay for it, you can go on whatever state, let's say it's the DC office, the health department, they're going to have a list of which agencies are licensed. Same with Virginia or Maryland. You want to ask, how are these employees screened before you hire them? They need to have had a criminal background check performed by the agency and a driving check. The same way you would do those if you were hiring somebody privately, you need to know that the agency has done that. I think an important part of this too is, how does the agency hire and train the caregivers? What background, what experience do they look for when they're hiring somebody, and what kind of training do they provide? I, for example, have done like a couple times a year, done training for some home care aides for an agency in Alexandria, and we cover everything from the PPE stuff to how do you deal with the combative client, and you need to know what kind of training this person has. And equally important is, how is this employee supervised? Because that's the one advantage to the agencies, and you're paying a higher price. You really need to know, if something happens in the home, who can you call and who's going to come out? If they have in their middle of a crisis and it's something other than a clear 911 call, you absolutely need to know that they're going to be able to get somebody out in your home. So how do they handle billing? I mean, that's a biggie, because you want to know, are they billing you by the month, by the week? Will they bill your long-term care insurance? If you have long-term care insurance, will they bill, or at least will they provide you with whatever documentation that you need for your personal long-term care policy? And, because it gets so expensive, you might want to ask if there's any kind of sort of a payment plan that's available. Most of these agencies are actually for profit, so the chances of getting financial assistance probably aren't great, but you certainly can find out if there is a payment plan available. And you don't want any surprises, so you want to know up front what the service fees are and what the details are of the cost you're going to be paying. So here's some questions that I would like you to think about to ask them. You want in writing from them a service plan that says, we've identified the needs of this individual for whom we'll be providing care. We will be in your home 3 times a week for 4 hours apiece. Here's what we're going to do. You want to ask about, are there limits on the type of tasks? You don't want to hire somebody to come in to do sort of homemaker stuff only to find out that they won't clean the toilet. You want to know what days the services are going to be provided, and because you may be trying, because this is expensive and there is no Medicare coverage for this. So you may be trying to sort of jockey your own time personally in there. What can you do versus what you have to pay for? So you need to negotiate what days of service are going to be provided. And again, I can't stress this enough. What procedures are in place if this aide gets sick? Because everybody gets sick sometime, and everybody needs a day off sometimes. And then another one, how do they address problems? Because there is high probability that somebody may not be working out. Or what happens if, your loved one has dementia and they say, oh, they just stole my grandmother's diamond ring. Who jumps in there to try to negotiate that? And some of the agencies require that there be a primary family member who's identified as a caregiver that they can communicate with. So you ask about that. Must there be somebody who's the primary caregiver? Because, if somebody lives alone and has no family, and, we live in Washington, D.C., we live in an area where there are a lot of people who are single and do not have family members around. So that's a pretty big one right there. Now, we were talking about cost. This is from Genworth. They are like sort of the guru of what things cost. When we were talking earlier about home health, and we were talking about the fact that it's theoretically cheaper, to have home health than it is to be in a nursing home. I want to just call your attention to the first three columns. One is a private nursing home, private room in a nursing home. In 2020, it costs $105,000 to have somebody in a private room in a nursing home. Assisted living it was 28,000 back in 2004. It's now almost 52,000. And another sort of sidebar about assisted living, the cost of assisted living has gone up a lot, number one. Number two, and I did a whole lecture at one point on what's assisted living and what gets covered, but with assisted living, and again, we're not going to get off the rails here on this one, but there's not a whole lot that's covered under assisted. So a lot of people will also hire private caregivers, home care aides to be with the person all the time. So that adds another, how many thousands of dollars a year. So the average cost of the home health aide, health operative word, is about almost $55,000 a year. And a home care homemaker is again about $54,000 a year. So we're not talking about costs that are for the faint of heart here. Okay, let's talk about hospice. I have had the good fortune of being the chief operating officer years ago when it was still called Hospice of Northern Virginia. And I headed up, had a fancy title, Vice President of Hospice and Home Health at the Washington Home when they still had the Hospice and Home Health program. So I feel like I'm sort of a hospice veteran and have the highest amount of regard for hospice care. So let's talk about the hospice benefit, because the hospice benefit is a Part A coverage. Medicare pays the agency a lump sum. It's called a capitated payment. And all of the services that agency provides are all covered under that capitated payment. So if you're a good hospice administrator, you keep your eye on the cost, because if you overspent, you're going to have to basically incorporate the costs, eat the costs. And that's why a lot of the nonprofit hospices will do a lot of fundraising to try to offset, because mostly they don't get enough money from Medicare. Medicare comes up with the formula, and how legitimate is the formula for somebody who's dying? I want to stress, I think hospice, people tend to think of hospice as just for people who have cancer, and that indeed is not the case. It is for anybody who has a life-limiting illness. So the goal is to help people who are terminally ill live comfortably with pain and symptoms well managed. So how do you qualify for hospice? Now, this is the part that's challenging for some people, because the two doctors, your primary care physician and a hospice doctor, have to certify that you're terminally ill. And that means in a hospice definition that you have a life expectancy of 6 months or less. You have to, if you are the patient, if you're the identified patient, you have to understand and agree to the fact that you acknowledge that you have only 6 months to live, or at least by best calculations. And you also, sorry, 1 second. I thought my honey tea was going to do the trick, but it hasn't. You not only have to agree to the fact that you understand that you have a life-limiting illness with 6 months to live. And again, there's you can't, there's nobody who knows exactly 6 months. But you also have to sign a statement that you chose hospice instead of the other benefits that Medicare covers. Because once you're in a hospice program, you're in a hospice program. And back to the other slide about the capitated payment, let's skip ahead. All of the services that you get are going to be in that one lump sum payment that goes to the hospice agency. So you agree that you have 6 months or less to live, and you agree to the fact that you understand that you're basically signing over all of your Medicare benefits to the hospice agency. So what does it cover? It covers everything you're going to need. It covers medical, social service, pastoral care, diapers, syringes. It covers really literally anything that you might need, including, and I think this is really important, including spiritual help, grief counseling, and anything that you might need afterwards. So bereavement is a really important part of this, and families have really come to count on that. And you have access to a bereavement counseling for a whole year after you're in a hospice program. So who are these hospice people? Well, I think they're pretty special people, to be honest with you, because it's not easy to deal with somebody who's dying and the family of someone dying, because you really, the identified client is not just the person who's dying, it's the whole entire family. And it's everything. It's physical, emotional, spiritual, etc. There is an RN and a physician that are on call 24 hours to give support. And hospice programs will provide a modicum of nurse aid services, but it's not daily. And many people have to have a private caregiver to help them with things like bathing and toileting and anything else that they might need. And I think that probably is, it probably is one of the hardest things that people have to come to grips with, because what they don't realize, I've heard multiple things. You say, yeah, they have a nurse's aide that can come in. Well, maybe twice a week for an hour or two, but what about all the other hours of the day? And that's something that I feel like the hospice programs have a responsibility to tell you, that they are not in your home 24/7. They have a doctor and a nurse on call 24/7, but they're not in your home 24/7. And I'm sure that you have heard people refer to going to hospice. And I think most people think they're actually going to a place. Whereas Medicare actually stipulates that the hospice care providers have to provide 80% of the care in a person's home. And if a person needs to go in for pain or symptom management, or because the family is in a crisis of some sort, it has to be the hospice team who determines that, and they have to make the arrangement. Altogether, there's 4 inpatient hospice units in the major DC metro area. The Washington home, I think, as most of you know, closed a couple of years ago. So Hospice of Northern Virginia, which is now, I think, called Capital Care, and changed their name a few times. They have a facility over off of Glebe Road in Arlington. I understand that they opened one out in Loudoun County. In Maryland, in Montgomery County, there is the Annie B. Casey House. And from what I understand, that Capital Caring also had opened was basically renting a floor in Providence Hospital exclusively for the purpose of hospice. I don't know. I think that's still the case. I know they were negotiating with Sibley to possibly rent, a floor or part of a floor in Sibley, and I'm not sure if if that happened, but. The inpatient care, again, I think it's so important for people to go in with eyes wide open, because the person is going to be in the identified patient is going to be in your home. They're not going to be somewhere else unless the hospice themselves determine that that's where the person needs to be. Again, let's talk about home care, because I would tell you that probably 85% of all people have some sort of home care that they hire by privately or agency. But and many people are really surprised by this, because they say, well, I have hospice. You do have hospice, that's absolutely correct. But I would say that probably of the people who hire help, they often will hire help for the night shift, because by the time you get to this place where somebody is terminally ill, you're exhausted, number one, and you need to sleep. And so a lot of families will hire, even whether it's private or through an agency, it matters not. They hire somebody to help them in the home. So Again, hospice is intended for people with a life expectancy of 6 months or less. And it's really, really hard for some people to come to grips with that. And so some people may say, no, absolutely not. I'm not going to sign it for him. I'm hopeful, God's going to cure me of my disease. Or the family will say, no, I can't abide by that. I can't come to grips with that. So what happens is if a person is signed into hospice, they're reviewed every 2 weeks by the multidisciplinary care team, which is, I think, is what makes this such a really robust method of care, is that you've got social workers and physicians and chaplains. You've got a whole bunch of people looking at this patient from a different perspective. So each person brings to the table their own perspective on how the person is doing, as well as how their family is coping. So basically, the care is there's a 90-day benefit period, and everybody. Let me just stop for a second. The actual review of the patient's care is every 2 weeks, and so Medicare requires that the agency evaluate this care on a regular basis. It doesn't mean that the person is going to get cut off after 60 days if they're still alive. But the hospice has to justify why they continue to be in there. And that burden rests not with the family, but it rests with the agency. And there are people who actually, and I know 2 of them off the top of my head, who have actually been discharged from hospice because it got to a point where the level of care was more of a maintenance care, and they weren't going to die anytime soon. And so the hospice basically had to discharge them, which is really, I have to say, I understand it intellectually, but it's a real hard pill for families to swallow and for the patient themselves, because, here they are. They geared up for the fact that they were told they had 6 months left to live. And all of a sudden they're being discharged from hospice because hospice is saying, well, oops, sorry, called that one wrong. Or, you're doing better than we thought you were. So I think these are a couple of things that I think are real important to remember. That, again, treatment is not intended to cure the illness. It's palliative care. It's managing pain and symptom management. And there is nothing more important in the world than to have your pain managed. The care in the emergency room or the ambulance can't happen unless the hospice themselves actually arranges it, or else it doesn't get paid. And Medicare does not cover any room and board anywhere, whether it's a hospice facility or if you live in a nursing home. Anything that happens, because the Medicare hospice benefit is all inclusive, it must be the hospice team who orders where you're going and what kind of care that you need. Excuse me. It's interesting because a long time ago, probably, again, it was the early 90s when I was with Hospice of Northern Virginia, but back then, home had to be considered an actual place of residence. The definition of what Medicare will consider home has changed pretty dramatically over the years. Hospice can now be provided in an assisted living facility, and hospice can also be provided in a nursing home. So that is a really positive thing, simply because of the fact that a lot of people literally are dying in assisted living and in nursing homes, and that's where they live. So that's where they're going to get the care. And it's also really helpful for the care providers in the assisted living and the nursing home. They have like another whole layer of services that they can count on, and people that they can rely on for advice about medications and pain and symptom management. If a person needs to be admitted to the hospital, it has to be the hospice provider that makes those arrangements. If a person or a family sort of freaks out and says, oh, my mother needs to go to the hospital, and they call the ambulance and have them go to the emergency room, the patient themselves and or the family is going to be responsible for the entire cost of the hospital care, which is one of the reasons why we had a discussion, I think it was I guess it was our last in the series of this, the one that occurred last month, where we talked about advanced directives. Hospice requires that a person sign a do not resuscitate order. Now, we're not going to recap that whole talk, but that's really important because that also implies, and the family's educated on this 100%, it says, if this person takes a turn for the worse, you have to call us, the hospice people. You cannot call an ambulance and you cannot send them to the emergency room. And if you do, you're going to pay for all of the hospital care, which if anybody's seen a hospital bill lately, I mean, it's frighteningly expensive. The hospice team determines if somebody might need an inpatient stay, or in many cases, a respite stay. They can tell that the family is absolutely wearing down. Again, that has to be arranged by the hospice program. And oftentimes what they will do is they will arrange that stay to be in a hospice inpatient facility rather than have somebody in an acute care hospital. And over the years, I've certainly seen it's really difficult. Some people just have absolutely intractable pain and it just cannot be managed. I mean, they can't, when you think about a lot of the pain medication, you don't want the person to be zonked, but you want them to be comfortable and pain-free. And sometimes that has to happen in a more structured, supervised environment than in the home. And so the person will be admitted to a short-term stay if there's a bed available in the hospice inpatient unit, but that has to be arranged by the hospice team. So again, the challenges are a lot of people resist signing a document that says we only have 6 months to live. One of the big things here is that doctors don't like to certify that a person only has 6 months to live. Number one, it's hard for them to tell people that. I mean, when's the last time you heard a physician be right up front and say, oh, by the way, you're dying and you have only 6 months left to live. The other conflict, and I say this with full respect, physicians have a hard time letting go. I mean, they've gone to medical school. They have got, and they've taken an oath that they will do the very best they can to care for and treat a patient. And a lot of physicians view signing over hospice as a failure on their part. Of course, it is not a failure, but a lot of physicians feel that way. So they're really reluctant to certify the patient that they only have 6 months left. And there are some cultures that are absolutely death adverse. And they don't want a person in hospice because that means they acknowledge that this person is dying. That's it for now. I think we're going to take questions in the chat room. These are the next 2 sessions that we're planning, and Erica will send out the notices of these, but just if you want to get them on your calendar. And I'm trying to decide if I talk too fast, but I tried not to because that tends to be something I tend to do on a regular basis. But you can email me if we have follow-up questions, or you can give me a call. Erica, can we take questions in the chat room? Yes. I guess I'm unmuting.
Yes.
Yeah.
First question, when is hospice team formed? By whom? Who are generally in the team?
The first person to come out and to assess the patient will be a registered nurse. And they are part of an admissions team. And the admissions team consists of the nurse who makes the assessment. I would say there's been experiences in the past that if they're not sure, they might bring a coworker, another RN along to make the assessment. And then the back office end of that then is a team of more clerical people that will work on, what kind of, is this really a life-limiting illness? How do we get this person plugged into hospice Medicare benefit? But it's an RN who does the first assessment visit. I think I can skip here.
Another question, and Mary, you might have to jump in and clarify this if I misinterpret. If you're part of Medicare Advantage at Kaiser, does all of this change?
I'm sorry, ask it again, please.
If you're part of Medicare Advantage at Kaiser, does all of this change?
Kaiser has to approve everything. The Medicare Advantage plan through Kaiser has to literally approve everything. And so they would have to make the referral to hospice. And I have to be honest, I don't know which hospice. I don't think Kaiser has a hospice, but I can't say that for sure. They may have the equivalent of a hospice program, but I actually don't know the answer to that, except that I do know that if hospice is being required by a person, it has to be Kaiser to make those arrangements.
Right.
With Kaiser, you can't do much on your own. You pretty much have to just use their services and their clinicians and their facilities. So like I said, whether or not they have it or not, if somebody has Kaiser, it might be worth a call just to ask the question of, do you have a hospice program? I mean, they may have contracted with one of the local hospice programs, but you couldn't access that on your own with Kaiser. Kaiser would have to make those arrangements.
So someone was asking about what services you provide with your consulting, Griffin Healthcare.
Well, a couple of things that actually I have been so busy with Medicare open enrollment this year has been really interesting because so many things have changed. I was sort of breathing a sigh of relief that last night at midnight was the end of open enrollment because I have been helping a lot of people to get it straight. I've worked with people on their long-term care insurance, how to get things paid for. I am not a geriatric care manager, but a lot of people, they kind of need to know where to start first. You know, do I need home care? Do I need an agency? What do I need? Do I need assisted living? So I would help people figure out kind of the early parts of that, maybe help them, teach them what questions that they need to ask. Which, by the way, if I can do a sidebar here for just a minute, because I forgot this, I actually created a document of 2 documents, basically. One that is the home care agency's checklist, if you will, what questions you should ask an agency, and also similarly a checklist for home health agencies. So what I will do is I can email those to Erica, and since she has your email, she can send those out. If we were in person, I'd be putting a piece of paper in your hand, but since we're not, we had to adapt a little bit here to the Zoom.
I know how valuable those pieces of paper are. We have a number of members who have said that that was just a lifesaver, having the right questions to ask. They help the process a lot.
Well, and back to in terms of the consulting practice, one of the things that I've been pretty busy with this year is as people turn 65 and or leave the workplace and have to apply for Medicare for the first time, it is literally like a foreign language. When I first retired, I created a class called Navigating the Complex Healthcare System. And I would work through the Georgetown retired faculty. And I remember the first day I walked into this classroom, and I'm pretty sure that most of these people were retired Georgetown PhDs. And I said, it doesn't matter how smart you are, how high your IQ is, what your experience is, Medicare is a foreign language. So I have been hired this year by a number of people who ask me, can you please help me? I don't know A from B, from HMO, from PPO. And I to be honest with all of you, Medicare Advantage plans have been advertised this year. There's billions of dollars going into TV ads for Medicare Advantage plans. And that just adds one more layer of complexity in terms of things that people have to decide. So hopefully that answered your question.
Put up your last slide with your contact information, please.
Okay, let me.
The next question is, how does DC's death with dignity, excuse me, I can't speak today, death with dignity law affect hospice care? If I choose not to accept treatment or refuse to eat, will the hospice agency support the patient?
I think the answer is yes. That would be a question that I would ask any hospice agency before I signed on with them. But the whole idea the concept, the overarching concept of palliative care is to keep a patient pain-free and comfortable. And so to support someone's decision to do that with a death with dignity, which, you know, is 3 cheers on my part. There's actually an organization called Compassion Choices. And for some reason, I think I made a donation at one point. Now I get a piece of mail about, you know, every 4 days from them. But one of the things that they are doing is they're working nationally on just doing exactly that. I think there are 12 states now that have the equivalent of DC's law, and they're lobbying all the time to try to have all of the states. And, you know, that's never going to happen in certain states. I think it's probably never going to happen, but to try to get as many states on board with that kind of a death with dignity concept as possible. But I would certainly ask the question. I would 100% make sure that if you're signing on with a hospice, you absolutely are sure that that's what they're going to do, to support you in that regard.
Thank you, MaryAnn. This was, again, amazing.
Eric, it looks like there's still 9 in the chat room from what I'm seeing here. Can you see that? My screen says 9 in the chat room. Maybe that just means how many there were.
Wait, we just got one new message saying that was wonderful. No, we've covered all of the questions in the chat room.
Because I see 10 chats in there. So I appreciate everyone's time. These are sometimes hard choices, but I think maybe having the handouts about how to choose an agency and how to choose, you know, decide on your own, hopefully that will be helpful. And if I ever learn the logistics of how to convert these slides into a handout, I will be sending those out too.
Thank you
So
so much.
if anyone would like any of that information that MaryAnn referenced, contact me at eblanton@palisadesvillage.org, eblanton@palisadesvillage.org, and I'd be glad to send it out to you.
Thank you, MaryAnn, a bunch. Thank you.
Oh, you're welcome. It was my pleasure. Erica, I'm seeing chat still. Maybe I'm just getting compliments here. Show the last
They're
slide.
just compliments.
Oh,
More people saying you're wonderful.
Who doesn't want a compliment, right? Can we record those, please? Speak into the microphone, as they say. Thank you, everybody, for being on board, and hopefully maybe you can join us for our next 2.
Yes.
Take good
Yes.
care.
After talking about long-term insurance, I'm sure that people are going to be interested in the next one.
Well, it's confusing and expensive and not nearly what you think it's going to be. So
Long-term care. Thank you. Thank you.
thanks, everybody.
Perfect. Wonderful. Wonderful.
Okay.
And we should be able to access the recording on YouTube.
Erica, yes?